Hello, friends. Good evening. Welcome to WDA. We are again here with a webinar. Dr. Saurabh Shah and Dr. Anand Mohta. Today we have our esteemed guest, a person, the pioneer of endodontics invention in India, make in India. We have Mandar Pimprikar, sir. We would like you to welcome Mandar Pimprikar, sir. Good
Hi,
evening,
sir.
sir. Welcome to
Good evening.
WDA.
Yes, good evening.
Yes, sir. A short introduction regarding Mandar sir. We all know Mandar sir, who's graduated in '93 and completed post graduation program from NIU and is practicing since 25 years. Sir has the biggest. Sir has invented and designed Endo Activator Plus,
Saurabh,
PATS Pro
why it was not
Activator Strip.
seen? Sorry to
Yes, I
interrupt you,
think
but
sir has. Yes, sir has exited. Sir is not there in. I think sir should be back soon. Hopefully.
let's wait out.
Let's just
So
wait for
till the
sir.
time sir is
Yes.
back, till the time sir is back, a few small announcements. So first of all, a very good evening and Eid Mubarak, everyone from all over the world who is following us on Endo Masterclass. Thanks a lot for the wonderful response. We are going crazy replying to your doubts and queries and everything. Keep on answering the questionnaire. Please keep on answering the questionnaires. Don't skip them. We will consider, we will give weightage to the people who have been answering the questions. No matter even if you're scoring less, you are making an attempt. That is very important to us. That is the whole point of going through this entire exercise and taking the effort of doing it. So please make sure you do that. Under small announcement,
Yes.
you might have seen we have rescheduled Dr. Zahir Al Taqi's session. So Dr. Zahir Al Taqi's session on MTA would be held on the 3rd of August. That is day after tomorrow. Saurabh, I guess we have sir back with us, so
Yes,
let's
sir.
continue.
Yes, sir. Sir, I'll introduce again, sir. We'll need your screen to be shared. We have Dr. Mandar Pimprikar, sir, today, who's graduated in '93 and completed post-graduation certificate program from NYU. Sir has invented, designed, and he, sir, is continuously upgrading Endo Activator Plus, PATS Pro Agitator, and tip system. And sir has formulated and patented Twin Clean, a single-step irrigation system in endodontics. Welcome, Mandar Pimprikar, sir.
Thank you.
Yes, sir.
Thank you,
Thanks
Anand.
a lot,
Sir,
sir.
will.
The stage is all yours, sir.
All right, all right,
Yes,
all
sir.
right.
Stage
Bye-bye.
is all yours.
I'll start with sharing of my screen. And
Yes, sir.
Yes, sir. We can see your screen.
okay, so are we all set to go?
Yes, sir. We are all
All
set to
set.
go.
Okay, all
Good to
right.
go.
Thank you, Dr. Saurav and Dr. Anand, for giving me this opportunity again. Because last time there was a lot of problem with the network, and I could not finish the entire presentation. So, although we have moved ahead in the masterclass series till a point of maybe ahead of obturation and completing with the post-endodontic restoration. Going back to clinical update on endodontic irrigation. Uh, Today being Saturday, I would have preferred myself to get irrigated thoroughly, but Anand and Abhishek requested me that we will have to do this session on Saturday. So enjoy this irrigation session where I'm going to focus on the clinical aspects of endodontic irrigation. What are we supposed to do? How are we supposed to do? Keeping it very simple, straightforward, and clinically oriented. So we all know that shape is dynamic when we do an endodontic procedure because we need to cut a shape to allow our irrigants to reach into the root canal system. So what is desirable? I would say instead of thinking what is desirable, we have to keep one thing in mind that we are shaping to clean. So, a simple, straightforward principle we have to stick to is shape to clean. So, we have to consider that what shape are we going to prepare to the root canal system so that it is easy for us or effortless for us to clean it completely and have predictable outcome all the time. So what is desirable? Is it 4 or is it 6? Now there is a lot of debate on having a taper, final taper of 4 or final taper of 6. 4, according to me, is a slightly smaller taper. 6 is to be considered nowadays an optimum taper. Anything greater than 6, that is 7, 8, and 9, are considered as a greater taper, which may invite post-endodontic complications. So, even if it is a debate, most of the clinicians think that I am able to get the canals clean when I shape the root canal system to a taper of 4. But we have to remember that being conservative is one approach. Second is, if we provide a greater shape to the root canal system, it is effortless cleaning, like you hit a 6 while playing a cricket and you take the aerial route and make it convenient for yourself to get the optimum results. So wherever possible, I would say I am a proponent of taper 6 wherever the anatomy allows us to shape the root canal to a taper of 6. Coming straight away to this article, which says the determination of minimum instrumentation size for penetration of irrigants to the apical third of the root canal system, and it was found that 30 ISO file we need to enlarge to an apical diameter irrespective of the taper, depending on what canal anatomy you are dealing with. 30 size is what we are looking at. So if you look at these 3 images here, one is 2004, second is 2504, and third is 2506. Now in all 3 situations, now when I say we are doing a shaping procedure to clean the root canal system, so in order to clean the root canal system, our irrigation needle needs to be placed within 0 to 1 millimeter of working length in the critical apical 1/3 zone. So if you consider a situation of 2004, your irrigation needle will lie 3 millimeters away if you're using 30 gauge needle. In a situation where you are dealing with 2504, your irrigation needle will lie within 2 millimeters of the apical 1/3. And when you prepare it up to 2506, your irrigation needle can lie in within 0 to 1 millimeter of working length. So that's the whole point we need to understand. Of course, there will be situations where you will have to restrict your preparation to a taper 4, but there is a rule or a law which we call it as tip versus taper. So when you reduce the taper, you keep the taper smaller, it is mandatory to increase the apical diameter. So when you increase the taper, it is always mandatory to keep the apical foramen as small as practical. So depending on the canal anatomy, we need to decide that what is the master apical file you are going to finish with your preparation. So the studies have told us that canals were found cleanest when they were shaped up to a taper of 6. So a clinical tip and a suggestion would be that wherever possible, go to taper 6 to have effortless cleaning, because taper will decide the volume of irrigant, and we all know that irrigation is a game of volume. Coming back to shapes, yes, there are beautiful shapes in the root canal system, like there in the ballet dancers, in the yoga poses. They are wonderful shapes. So, but we have to also keep in mind, we are not going to only focus on shaping the root canal, managing the curvatures, the convexities, the concavities, but we have to keep in mind one important aspect of the entire procedure is the biological considerations, which we often overlook, because we want to be predictable from this situation to this situation, from this situation to this situation. So biological considerations needs to be paid attention so that we disinfect the root canal system and get these outcomes, predictable outcomes all the time. So what we need to do know about the endodontic irrigation, why are we doing irrigation? why is it so important, and how are we going to do it, or how are we going to execute the endodontic irrigation in day-to-day practice. So I was told that the most of the registered participants to this masterclass are newcomers or few years into the practice. So I'm going to speak very basic about endodontic irrigation with some advanced techniques. How do we actually perform endodontic irrigation in your clinical practice? So if you look at this video now, this will explain why the endodontic irrigation is so important. Now, when you look at this model where a file is rotating in the canal, as the file is rotating, you will see that it is not contacting all the canal walls. It is pushing debris into the inaccessible areas. When you go to the other canal, you see apical vapor lock, which exists, that there is no solution in apical 1/3, and a file cannot push the solution into the apical 1/3 and break the apical vapor lock. So as the file rotates or reciprocates, whichever way you do it, it is going to generate a lot of accumulated hard tissue debris, which starts to get packed into the lateral canals and the dentinal tubules. Now, in this section tooth, you will see every rotary or reciprocating file generates a lot of accumulated hard tissue debris. Now, if you look at here, this starts to build up a smear plug. Now, if there is a lateral canal here, and when you start instrumenting, it starts to build up an accumulated hard tissue debris, and it starts pushing the debris into the inaccessible areas, which will in turn prevent the penetration of your irrigants or antibacterial solutions, and that portion of the root canal system will be left untouched or untreated. So it is always important for us to deliver the irrigant in a proper way. In a copious amount of the solution is required, and we have to drive the irrigant in such a way that it creates some shear stress on the canal walls, and it removes the debris from within the root canal system. So it is always advisable for us to instrument in the presence of the irrigant. So now we know why it is so important, because canals are never round in cross section. File do not contact all the canal root surfaces. There are anatomical variations which we will see in later part of the presentation. And metal cannot kill microorganisms. You need antibacterial solutions. Cleaning of debris is of paramount importance. So we have to focus and keep those biological considerations in mind whenever we do endodontic procedure. So coming to challenges, what are the challenges we face? So there are going to be uninstrumented parts in the root canal system. The isthmus shaping and cleaning is a fundamental step. Dentin as a canal, every dentinal tubule can act as a canal. There is going to be a smear layer which is generated. We have to dissolve the organic matter from main body of the canal and also from lateral canals. And we are dealing with the biofilms, which are monospecies or multi-species. So these are a set of challenges we have to overcome when we do endodontic irrigation. What does this study tells us? This is a micro CT analysis of the distal root oval canals, that it's only about 40 to 45% of the time the endodontic file will contact with the root canal surface. So the question is, can we really do better in terms of impacting the inaccessible areas? Another study which tells us that the difference between the touched and the untouched surface here, the isthmus, which is completely loaded with the debris and the bacterial content or biofilm. So we need an irrigant which will act on these inaccessible areas so that we completely clean the root canal system. Now, this was one of my case where the tooth went under extraction because it was failing. And for my curiosity, I cleared the tooth just to see what actually went wrong, because on radiograph, it was looking perfect. So if you look at here, there was this interconnection, there was this mesial third, and there was a lot of debris which I tend to pack during my instrumentation. So in spite of obturation looking good on radiographs, there could be an inadequate cleaning which happened, and that is why the case could fail. So we have to pay attention to those inaccessible areas, because that's one of the biggest challenge to when it comes to treating the root canal system. Now, if you look at this radiograph, the obturation looking reasonably fine in the vertical extent. We don't know about the other extent because that's a two-dimensional picture. And the patient was experiencing discomfort, pain, swelling on and off. So I decided to take and go for a CBCT, where it was revealed that there is still a periradicular lesion which is still present in spite of it is not seen on the radiograph. So in such situations, when you do go for revised treatments, it is advisable to go for a CBCT and see what actually the third dimension tells you. So when we treat this tooth, and then you can see the apical ramifications being filled, and now there will be a healing. Of course, we need to take a follow-up of this case and see whether it heals or not. The message here is whether we are doing this cleaning procedure adequately or not in our day-to-day practice. We have to do this dedicatedly to get these outcomes. So the question is to fill or not to fill. Whether you really want to fill those apical ramifications, lateral canals. Somebody would say, "Kya farak padta hai? How does it matter? Will it affect the success rate? How does it matter to me? And is it really necessary?" For this, we really need to understand the lateral canals and the apical ramifications. Lateral canals is the single canal extension from the main body of the canal which communicates to periodontal ligament space. And if this lateral canal tissue is involved in the periradicular disease, it has to have some periradicular or lateral lesion where the toxins are getting deposited. So when you see a lateral lesion on radiograph, that indicates that there is a lateral canal, and which is depositing toxins into the pedial space, and which needs to be intentionally cleaned to reverse that periradicular disease. When it comes to the apical ramifications, now Schilder postulated that the main objective of endodontic treatment procedure should be the cleaning and filling of the root canal systems in its entire extent, including lateral canals and apical ramifications. But clinically, if there are no signs of the lateral canal or the apical ramifications being involved in the disease process, say for example, when we are dealing with vital cases, it may not be really necessary to impact on those lateral canals, because if it is not contributing to the periradicular disease. But clinically, we don't know. It may not be in a stage or a state where it is not depositing the toxins. And if you miss on those lateral canals, sometime down the line, it may cause the periradicular disease to progress. So for that, we need to know the fate of the tissue in lateral canals and apical ramifications. There's a very beautiful article on this. So unfilled lateral canals can cause a case to fail maybe few years down the line if it is not treated. It could cause recurrence of the periapical disease, and there could be pain during and after treatment if the lateral canal or apical ramifications are not taken care of. Because if you're not impacting on those areas, not in terms of instrumentation, but in terms of doing an activated or agitated irrigation, so that your irrigating solution takes care of that tissue which is lying in the lateral canals, is of critical importance. So when you see such radiographs here preoperatively, where you have a lateral lesion, where you have a thick bulbous root and a periradicular lesion, a furcation lesion, and a clear lateral lesion, these are the indications where you have to suspect that there will be more than one portals of exit apically when there is a periradicular lesion. You have to suspect the accessory canals in the furcation area when you see a furcation lesion, when it is of a primary endodontic origin. And we're not going to go into the details of endoperiocontinum, but when it is primarily endo, you have to suspect that there will be accessory canals in the furcation area where the toxins are getting deposited into the periradicular tissues. And of course, when you see a lateral lesion, you have to have a strategy to clean this lateral canal intentionally. So this is the point, and this is the challenge what we have to overcome, and that is why we have to stick to a concept that is called as instruments shape and irrigants clean. You need an effective irrigant which reaches the apex, create current, and remove the debris. So as the first study which I showed said that only 40 to 45% of the time the root canal file actually contacts the canal walls. Rest of the work is actually done by your irrigants and activated irrigation devices. Coming to anatomical variations of the root canal system. Now here, these are some of my, where I do the clearing of teeth to study the internal anatomy. Here you can see a mesial third emerging from mesiobuccal root and actually has a separate exit. So essentially this becomes an uninstrumented part for my root canal instruments. Look at this complex anatomy where I don't think any file will take care of this anatomy only by mechanical way of preparation. So you need to combine this with a copious amount of irrigation where you will shape the main body of the canal and allow your irrigants to get pushed into the lateral canals and the accessory canals. Some more images here. You can see the multiple portals of exit here, 2 portals of exit, then the lateral branching, then the lateral canal, then the 3 or 4 portals of exit, the lateral canal in apical 1/3, the bifurcations. So these are all there. And it is our primary job to fall into the main body of the canal and allow your irrigants to impact on those areas where your files will never reach. So we have to have a strategy. Now, every clinician has a protocol to follow when they do a root canal instrumentation, like 10, 15, 20, 25, or whatever, whichever file system they use. But when I ask what is the irrigation protocol, nobody has an answer that as to what irrigation protocol they are following. And I think that is where we are not paying attention to the biological considerations of the whole treatment. So if you're using some form of magnification, you will see that after doing an instrumentation, you will see a lot of debris here. And when you use magnification, you will see how much accumulated hard tissue debris your file generates. So cleaning of debris is of paramount importance. Now, when you start with your access preparation, normally after doing isolation with rubber dam, doing a pre-endodontic build-up, then you complete the access preparation. The idea of pre-endodontic build-up is to allow your irrigants to get contained into the prepared access cavity and allow some time for irrigant to digest this small tissue tags where no instrument can remove this. Of course, you can use ultrasonics to refine the access preparation when the irrigant is present in the access cavity. So once you do that, that's called as passive wait, what I follow in my clinical practice. Once I open my access, done with the access preparation, I pour few drops of sodium hypochlorite or twin clean, which I will explain what twin clean is, and wait for 1 minute. That's called as passive wait. You can agitate that solution with either DG16 probe manually or by way of ultrasonic to refine and scout the orifices, the possible locations of orifices. Once you have given about a minute or 2 for sodium hypochlorite or twin clean to act on the access cavity walls, you will see a bright, shiny floor. And on this bright, shiny floor, because hypochlorite has a bleaching action, you will be in a better position to locate the orifices, and you will not miss on the accessory orifices. So that's the whole point where you have to, the cleaning starts from the access preparation. It's not that you shape the entire thing and then start cleaning. It's simultaneous process. So when you do instrumentation in a single rooted tooth, the file starts rotating, and then you are in a better position to auger the debris out when you're dealing with a single rooted tooth. But when you're treating a multi-rooted tooth, suppose this is mesiobuccal, your file starts rotating and this starts to push the debris into the isthmus area. So whether you rotate or you reciprocate, in both the situations, the debris is going to get packed into the isthmus. So after every file you work on, there is a need to copious irrigation and push the debris out, and do not allow the accumulated hard tissue debris to get packed into these inaccessible areas, because it's a blind procedure and you don't know how much it has been removed. So if you allow some time for it to get packed, it is going to be difficult for you to actually get rid of all the debris at the end. So now we know why irrigation is so important, why it is strategically so important, and we know the limitations, we know the challenges we want to overcome. Now let's see how are we going to do it, and what are challenges involved in activating or reaching the irrigant, or how do we choose an irrigant, and what do we use, how long do we use, and how do we enhance our irrigation, and what really works for us in day-to-day practice. So again, the conclusion slide which I showed you about tip versus taper. So if you are keeping the taper as 4, it is advisable to increase the apical diameter to at least to 30 or 35. And if you are giving a taper of 6, then it is 25, which is minimum. And then depending on the initial apical gauge, you can decide your master apical file when you are giving a taper of 6. So the message is, wherever possible, looking at the pre-operative radiograph, you take 3 radiographs in 3 different directions. That will allow you to assess the width of the root, and allows you to visualize that how much dentin will remain behind after you use your master apical file. So in my day-to-day practice, I am a follower of a 6 taper. 4 taper, yes, in some situations, but then you need to focus more on activation and agitation. And when you are with 6 taper, it is more or less slightly easier, because there is shape, there is more tapered shape. So free exchange of solution happens when there is 6 taper. So there are 2 schools of thought. One is keeping the apical diameter as small as possible and play with the taper. That is what works for me all the time, instead of increasing the apical diameter, because the most of the complex anatomy is in the apical 1/3, as you can see here. So if you increase the apical diameter here, then you may be damaging or altering the normal canal anatomy, and you may invite accidents like transportation and zipping of the apical foramen, which is not conducive for the obturation techniques. So keep the apical diameter as small as possible, and you can play with the taper depending on the thickness of the root. If you can have a look at these clear teeth images, where you can see lateral canals, where you can see bifurcations, where you can see trifurcations, where you can see apical ramifications, where you can see network of lateral canals. So all these are gettable if you have a strategy to shape the main body of the canal and allow your irrigants to work on the other part of the split. So first step after the access preparation is isthmus shaping and cleaning, which I call it as fundamental step towards long-term success. As you can see, isthmus and interconnections getting filled here very consistently. If you're not treating this, you may be at a chance of not treating about 20 to 25% of the root canal system, which is left untreated or untouched by either by your instruments or by your irrigants. So when you start like this, and then what you have to do is use ultrasonics and remove this thin lip of dentin, and then you uncover this area, where then you will be in a better position to search for the mid-mesial or mesial third, which is most of the time present when there is unusual large distance between mesiobuccal and mesiolingual. And this is how your final picture should look like: clean, shiny floor. And here I have tried to demonstrate the isthmus cleaning after it has been shaped. The tooth has been decoronated, so that you can visualize what actually happens at the isthmus level. So there is a lot of tissue trapped here, and this is area where the percussion area where the toxins keep on getting deposited into the percussion area. And if you really do not impact on these areas, uh, your percussion lesions may not heal. So that's a step everyone should incorporate into your day-to-day practice when dealing with the multi-rooted teeth or maxillary premolars, where you will have this isthmus. So first step after your access preparation is pour few drops of quinine or sodium hypochlorite. Allow 1 minute for its action. You will see bubbling, and when you shine the light cure light to the tooth, it actually looks like an champagne. So it's called a champagne test. From wherever the bubbles are coming out, that could be your orifice. So that's another tip where you cannot miss on the orifice. Always instrument when the canals or the access cavity is filled with irrigant. Irrigation starts at the access preparation. Reaching apical terminus is our goal. Always try and maintain contact of the irrigant throughout the procedure that satisfies the contact of hypochlorite within the root canal system. And once master apical file is done with, then the disinfection begins. So all this time, irrigation is only to auger the debris out, clean the canal system, and reaching the apical 1/3 or apical terminus is the goal, and disinfecting that apical 1/3 is a challenge. So after your master apical file is completely done, then you start the disinfection process by way of activating the irrigant. So talking about irrigants, we have sodium hypochlorite as antimicrobial agent. We have chlorhexidine 2%. We have some chelating agent, which are divided into strong and mild chelating agents. So now sodium hypochlorite remains the indispensable solution in the endodontics till the time we find something else, because only 6% of hypochlorite was able to completely remove biofilm and prevent its. So it definitely has an advantage over chlorhexidine, although chlorhexidine has good antibacterial property, but it lacks the dissolving property. So, and it also has a substantive action, chlorhexidine. So when you use agent, it has factors which will govern the irrigation with hypochlorite. So volume of solution used. Schilder used in 1974 about 39 ml of hypochlorite per visit, which is combined with patency filing. Now, if you do not achieve patency or maintain patency, the whole treatment is at stake. And I call it as no patency, the prognosis is questionable. So if we are not Schilder, if you're not using 39 ml, at least we should use 15 to 30 ml of sodium hypochlorite per visit. Now there was, I don't know, there was one session which was about 1 visit and 2 visit or multiple visit. Now I am a proponent of 2 visits because my second visit is only dedicated to irrigation. It's only cleaning. So in first visit, I do irrigation and cleaning, but combined with my instrumentation. Once my master apical file preparation is done, then in the same visit, there is disinfection done, and the second visit is kept only disinfection. So volume is absolutely important when it comes to using sodium hypochlorite. Contact time with the tissue, I showed you in a video that the irrigation starts from your access preparation. You maintain the contact of hypochlorite or a single-step irrigation solution throughout your procedure to allow hypochlorite to completely act on tissue. Concentration of the irrigant, it is available in 3% and 5%. If you're using 3%, you may have to increase the volume. If you're using 5%, you can somewhat settle down for a lesser volume than what you use for 3%. Temperature of the irrigant, there is so much in the literature that if you increase the temperature of hypochlorite, the action is actually double in terms of digesting the pulp tissue, and there is increased antibacterial action. Refreshment of hypochlorite is also critically important, as as the volume is, because if you're using greater volumes, you need to refresh the hypochlorite, because the moment hypochlorite comes in contact with the organic matter, it degrades very fast. So you have to constantly keep on evacuating the old solution and introduce the fresh solution all the time. And of course, agitation and activation is important. So finally, we can say that greater the volume, longer the contact time, higher the concentration, higher the temperature, refreshed frequently with activation, there will be more penetration of hypochlorite, and that is what we need, because every dentinal tubule can act as a canal, and the microbes are sitting quite far inside, deeper than 300 micrometer. So coming back to the increasing the temperature of hypochlorite, there were few studies which states that 1% of hypochlorite at 45 degrees dissolved pulp tissue as effectively as 5.25 solution at room temperature. So it is a good idea to use a warm hypochlorite. Now, how do we do it? I will cover it in a later part. So what do we know about the sodium hypochlorite is it eradicates the biofilms. It will prevent its growth. It can kill all the microorganisms on direct contact within 20 to 25 seconds, provided you make the contact. Although chlorhexidine kills bacteria, it lacks the ability to hydrolyze the pulp tissue, and it is completely ineffective against biofilms. So chlorhexidine per se has got no place in the endodontic procedure. It may have its role in terms of intracanal medicament, but not as an irrigant. So we have to think about the depth of hypochlorite, which will depend on concentration, time, and temperature. And activation or agitation will further increase the penetration of hypochlorite. Also, we have to see what hypochlorite we are using, whether you're using hypochlorite with the surfactants, because it will increase the wettability and it will definitely allow penetration to a greater depths if you're using hypochlorite with the detergents or surfactants. There are a couple of products available where you have surfactants. There are also these commercially available products which are combination of some irrigating solutions, but we have to remember these will be effective only when hypochlorite is primarily used. So ultimately, we are not getting away by not using hypochlorite, because we do not have any substitute which will replace hypochlorite. And also, we should know that the hypochlorite which we use is actually reacts with every reagent what we use, like EDTA, all the free chlorine to be released. If you mix it with chlorhexidine, it forms a brown compound which is parachloroaniline. With citric acid, it tends to form salts. EDTA and chlorhexidine, that is Q-mix, it also forms salts, and it is the hypochlorite will react with each and every reagent we use in day-to-day practice. And that is why we have this protocol in place where we use normal saline after every solution which is used. So the slide which you are looking at is the irrigation sequence during and after instrumentation, where I prefer to use EDTA gel, not now because I am using single step irrigation now, which I will explain you. But if you want to follow a traditional irrigation protocol, then EDTA gel during instrumentation to establish the glide path. Then use normal saline, irrigate with 3% or 5% hypochlorite, preferably warm. During rotary instrumentation, use hypochlorite, and only hypochlorite. After that, rinse it with normal saline, then liquid EDTA, 17% aqueous to remove the smear layer. After your master apical file is done, then you start the disinfection process by using warm hypochlorite with activation or negative pressure, that is 1 to 3 minutes per canal, and again rinse it with normal saline to remove the hypochlorite, and again use liquid EDTA 17% for a minimum of 1 minute with activation to remove finally whatever smear layer is left behind. And then a rinse of normal saline. And then if all the parameters are falling in place, you proceed for obturation. So this is what the irrigation sequence which we always follow. But what I thought was, why not to have something which will act as a single step irrigation solution. As you saw in the videos that hypochlorite reacts with each and every reagent, let it be EDTA or citric acid or chlorhexidine. Now there is one chelating agent which is etidronic acid, which is a mild chelating agent, which is compatible. There is a short compatible window with hypochlorite. And when you mix a proteolytic agent, that is hypochlorite, with this etidronic acid, which is a mild chelating agent, which is freshly mixed, this can be used as a single step irrigation solution. So you really don't have to remember a sequence or use alternate solutions and increase the inventory. So like now we have everything for our composite restorations. You get a single plant which does everything: etching, bonding, priming, conditioning. This is the same concept where we can use in endodontics to have only one solution which will have all the desired effects of an ideal irrigation solution. Now, if you talk about this twin clean, it is not only a solution. We must understand it is a concept. It is a concept called as chelating, continuous chelation. What is continuous chelation? If you go back to the previous slide of the irrigation protocol sequence, where hypochlorite is not able to remove the smear layer, so we use liquid EDTA to remove the smear layer. So ideally what we are doing is we are letting the smear layer getting built first and then try to remove it with EDTA later on. So when you are using this continuous chelation concept, you actually do not allow any smear layer to get built up because chelating agent is actually present in the solution. So if the smear layer or accumulated hard tissue debris is not getting built up on the canal walls, your lateral canals and dentinal tubules are patent enough to receive hypochlorite. That way the penetration of hypochlorite is increased. So that's a valid point for continuous chelation. If you keep EDTA more than 2 minutes in the contact of the dentin, it is erosive because it is strong chelating agent. And being etidronic acid as a mild chelating agent, you can have this single step irrigation solution to be left in the contact of the root canal walls while shaping, after shaping. This will not erode the dentin and also will condition the dentin to receive the sealer. Now, why it has to be mixed fresh? Because there is a compatibility window of about 120 minutes. So when you mix the solution, you have to consume that in 120 minutes. So when you start your access preparation, you can ask your assistant to freshly prepare the hypochlorite. Now the hypochlorite which you can use is, I would suggest that 3% hypochlorite is enough to use with continuous chelation concept. What is the advantage of this single step irrigation in terms of taking care of the E. faecalis? And that is the only one reason we use chlorhexidine to get rid of E. faecalis. But when you mix this solution fresh, the pH of the solution is about 11.86. Now, if you look at the studies, at the pH of 10.5 to 11, you can delay the growth of E. faecalis. But the pH which exceeds about 11.5 or greater than that, the E. faecalis was killed. So 10 minutes of single step irrigation, twin clean, direct contact time with the root canal system, E. faecalis biofilms can be eradicated. Of course, you have to use agitation techniques in order to make this single step irrigation solution available in the inaccessible areas. So the choice is up to you whether you want to follow the complete protocol by remembering a sequence, or you just use one solution and you only need a normal saline with activation to remove the remnants of the solution. So there is a better smear layer removal as compared to the hypochlorite and EDTA combination. There is a better anti-biofilm activity. There is no dentin erosion. The continuous chillation irrigation improves the adhesion of epoxy resin-based root canal sealer to the dentin. And continuous chillation is quite favorable to all type of sealers which we use now. Let it be epoxy resin sealer, let it be bioceramic or bioactive sealers, or an MTA based sealers. So that's a concept which was introduced in 2016, which is when I started working on it. And this month of May 2020, the patent was granted to me for this single step irrigation solution. So advantages being reduction, there is marked reduction in accumulated hard tissue debris, and the pH is 11.86. So it's up to a clinician's choice whether they want to follow irrigation sequence and maintain the inventory of all these solutions, or have only Twin Clean, which will act as a single step irrigation solution in endodontics. So continuous chillation will help you to clean the debris. It will help smear layer in a better way and an effective way, and it will also side by side condition the dentin to receive the sealer. So this was all about the irrigating solutions. Now let's look into some of the aspects of the fluid dynamics when we do the irrigation. We have to take care of the apical vapor lock effect. We have to know the stagnation plane, and we need to know what is the depth of the irrigation. I'm not going to go into the details of apical vapor lock, but it does exist. But if you increase the taper to 6, the problems removing this apical vapor lock effect are lesser, because there is a greater shape and there is a better exchange of the fluid. Of course, you need to break this apical vapor lock mechanically by using some device where you agitate the solution. Then this was a study by Dr. Gulabiwala, which says that there is a dead water space or stagnation plane. Imagine a situation here, you're irrigating a maxillary tooth, there are two side ports, and you start to push the irrigation needle, irrigation solution, the solution trickles down. Plane is here, the solution does not travel 1 millimeter beyond the needle tip. So, and we are looking at a passive irrigation, we are not doing any forceful irrigation. We are not in a position to deliver the irrigant into the critical zone, that is apical 1/3. If you are using now this is a 27 gauge needle. So first slide I told you shape. So we need to create a shape where your 30 gauge needle will lie within 0 to 1 millimeter. So now it is clear understanding for everybody that we have to use 30 gauge, so that you reach within 0 to 1 millimeter of the working length. The apical vapor lock, yes, it does exist, and we really want to get rid of this apical vapor lock, because if you're not making the solution available in apical 1/3, the whole point is, there is no point in doing irrigation. So, and we know the solution does not travel, or the flow is just laminar flow ahead of the needle tip. So again, the same tip versus taper. I will not go into the details of this, but what type of needles we are supposed to use is never use those hypodermic needles. Don't use the side cut needles. These are negative pressure cannulas which has multiple holes, but this can be used for negative pressure irrigation. What we have to use is side vent. Now we get two vent needles. Now primarily my recent work was on this comparison of parallel sided needle versus tapered needle, and also the grip of the syringe also matters. Never use the thumb grip, use a palm grip, so you have a better control over irrigation. And we really don't want these irrigation accidents into our clinics. This typically happens when you try to extrude the irrigant, you lock the needle. So never lock the needle. Your preparation should be such that there is a space or backflow for your irrigant. The moment you lock the needle and exceed the venous pressure, that is 40 to 44 millimeters of mercury, you are going to push the hypochlorite or irrigant into the venous aperture, and then you get this hypochlorite accidents. So my recent work was on developing a plastic flexible needle which is tapered and with 2 holes. Now, if you look at here, 0.26 ml per second is what we need to achieve to have a 15 ml of solution delivered per minute. Then only you can order the debris out when your needle is lying passively in 0 to 1 millimeter of working length. Since this is apically blocked, your irrigation is not going to get pushed into the periradicular tissues. Now, when you have a single vent needle, you really need to rotate the needle so that all the canal walls are really rinsed properly or cleaned properly. With double vent, it's almost covering all the uh, canal walls. So this is twin dent, which will be introduced in a couple of weeks, which has 2 holes, and it's a tapered needle. It's flexible needle, and since it's a tapered needle, you will see what actually it makes a difference. Now see, this is 30 gauge parallel sided needle with a side vent, and this is tapered needle. Now look at the pressure which I am requiring to push the irrigant with 30 gauge parallel sided needle. And I hope all the clinicians will appreciate how much is the pressure and how it really is painful. Now see how much pressure I'm applying, that the whole station is moving forward. So there is you need a lot of resistance to empty a 5 ml of syringe with parallel sided needle. And whereas when you have a tapered needle, it is effortless but still effective. Without any pressure, you can empty a 5 ml of syringe in time that is calculated here. Parallel sided, it takes about 1 minute 44 seconds to empty a 5 ml of syringe. For tapered needle, it takes only 25 seconds. So in order to have a laminar flow, from laminar flow to somewhat turbulent flow, to have a greater flow rate so that the debris is taken out or washed out. So for say 5 ml of syringe, 5 ml of solution, when I'm extruding 15 ml, I will need only 77 seconds. So that is definitely advantageous over a parallel sided needle. And that is why most of the companies now will come out with the tapered needles. So what are the take home messages? Is the closed ended needles need to be placed 0 to 1 millimeter short of working length. During irrigation, the needle should be moved longitudinally inside the root canal up and down so that you don't lock the needle and do not block the backflow of the irrigant. Root canal needs to be enlarged to a size of 30 or 35, combined with increased or decreased taper, whatever the canal anatomy allows you, and a relatively high flow rates, which is achievable with the help of the tapered needles, which is about 0.25 ml per second, which comes to about 15 ml per minute. So that is how we can use more amount or volume of irrigation. Then coming to the last part, that is objectives of irrigation, that it should reach the full extent, it should ensure the adequate delivery, it should allow the refreshment, you should ensure some shear stress so that the debris which is sticking onto the walls is, and you are ensuring some shear stress on the canal walls to get rid of the disorganize the biofilms and allow irrigants to penetrate deep to kill the bacteria which are protected by biofilms. And it should be confined to the root canal system, and it should also provide lubrication. So this is what you do to a tapered canal, where you have a nice taper and the whole canal is filled with the irrigant solution. Anion dynamic agitation, passive ultrasonic irrigation, sonic activation. You have air sonics, which I have developed, that is called as pro-agitator tip system. You have negative pressure irrigation, and you have intracanal heating. So this is just for the beginners or the clinicians who have recently started their practice. Lock the needle inside the canal. Use a surgical cannula, which can and continuously move the needle up and down so that you allow some backflow of the irrigant and never push the irrigant. This is how the manual irrigation is done with. Then manual dynamic agitation, I hope everybody knows about it. You prepare your master apical file, select a master cone which is one size bigger than your preparation, so that your master cone is automatically shorter than your working length for about 1 to 2 millimeters. And you fill that prepared canal with irrigating solution, and with short amplitude strokes, about 30 to 40 strokes per minute. Uh, uh, Here it is thought that when the GP is moving up and down, it carries the solution with it, and you are in a position to break the apical vapor lock because it is customly fitting into the prepared canal. Sonic, we all know that you have a device called Endoactivator or Glyn. There are a couple of them in the market. So that's a sonic system, and it does not uh, have a frequency. It is more of amplitude and lesser frequency. Ultrasonics, you have primarily working on the frequency. But the problem with ultrasonic, although it is the most efficient way of activation, the ultrasonic activated irrigation is typically done with the metallic files, which tend to alter the canal anatomy. And you really can't take care of the curved canals because there is a chance of fear of separation of the file when it is activating into the curved canal. So what I thought was, why not to have a system which will be as effective as ultrasonic, being frequency based, and give me an advantage of flexibility in terms of sonic, of having a polymer tip. I think most of you must have seen the videos of Pro Agitator tip system, but since it has been developed by me, I will. It is better that somebody else talk about the opinion on this, so that it becomes an unbiased. So
we are back again
just listen to this
another very useful clinical video, which is about comparing the various irrigation devices that are currently available in the Indian market. Yes, including me, I've always had this confusion of selecting the proper irrigant activation device, starting from the ultrasonics, the sonics, the expensive ones, and the cheaper ones, all of them that are available in the market. Right? So we sometimes end up buying something expensive and then we realize that it's not working out for you. Or you sometimes buy a cheaper product and then you realize that it's not up to the mark. So here we have 5 products that are available right at the moment in our country. So let's see how each one of them perform in the demonstration that I'm going to show you. Then you can decide which will suit your own practice. So here we go. Let's watch the video. We're going to discuss about 5 different irrigant activation devices available in the Indian market. Endoactivator from Dentsply, IriSafe from Satellite, Pro Agitator by Innovations Endo, Ultra X from 18th, and the Glyn Activator. First, we'll be discussing about the Endoactivator from Dentsply. It's a sonic irrigant activation device. When I say sonic, it means it's less than 20,000 oscillations per minute. So the endoactivator has a maximum oscillation of 10,000 cycles per minute. The smallest tip, that is a 15.2% polymer tip, is used. The polymer tip cannot change or alter the shape of the canal. It doesn't create ledges in the canal. So that's a big advantage of using a sonic with polymer tip. The Glyn is almost a similar activator like an endo activator. It's a much cheaper version, but it's little crude, as you can see in this picture. The one on the right is the Glyn tips. This also functions exactly like the endo activator. It's also a sonic one. It also oscillates around 10,000 cycles per minute. Next is Ultra X from 18th. This is different from the other two. It's an ultrasonic device. It's nothing but a scaler which has 2% tip. The drawback of this system is a stainless steel tip, which is too stiff. As you can see in this picture, it can actually cut the canal, which can change the canal anatomy, and there's a very high tendency of creating a ledge in the canal. So it's difficult to call it as an irrigant activation device, but the manufacturer claims that this can also be used for instrument retrieval and other purpose during retreatment. When it comes as an instrument agitation device, it doesn't score well. The next one is the IriSafe tips from Satlac. This is also a metal tip, but it's more flexible. It has a safe end. It's a 22% tip as well. But you can see here that the tip is more flexible compared to the spreader tip that was provided with the Ultra X. This is also ultrasonic, meaning it is above 20,000 Hertz. Activation with this is also called Endodontic Irrigation. These tips are compatible only with the Satlac scaler. It cannot be used with Chinese scalers or the EMS scalers. The next one is a different mechanism agitator, which is called air sonics. This is attached to the aerator chair. It works just by the air compression. This also uses a polymer tip, and as you can see here, this looks the most powerful compared to any other activation devices. In this demonstration, we are using EDTA for activation. You can see that this is far more superior in terms of power when it comes to activation of the irrigants. Also, it's more economical compared to the other devices. So now it's time to critically analyze these systems without any bias towards any particular product. When it comes to sonic and ultrasonic, some studies clearly sonic device is much better than ultrasonic, and definitely a polymer tip is preferred over a metal tip. And it cannot change the anatomy. It does not create ledges in the canal. Chances of breakage is very less, as the longevity of these tips are very high. But when you compare the cheaper ones with the expensive one, as we already discussed, the one on the right, you can see here that the tips looks more crude. This is the tip of the pads or the Pro Agitator. This is nicely finished and extremely flexible. The only drawback is the smallest size available is at 3%. So maybe if they come up with a tip, it may have more space for oscillation.
Okay, so here there are where you can see the activation by the Pro Agitator tip system. Thanks to Dr. Paras, Dr. Ashish, and Dr. Advait, who have shared this video and their experience. This is a completely indigenous product. All right.
Hello. Yes, we had some internet issues. We are back, sir, online.
चालू है ना, दिख रहा है ना अभी? Okay. So coming back to negative pressure. So negative pressure is quite safe because you're treating the whole length of the canal, as the cannula is placed into the apical 1/3, where the solution is sucked at the apical 1/3 when you constantly keep on dropping the irrigating solution into the pulp chamber. So this is the concept of the negative pressure. Now, the last method of activating the irrigant is intracanal heating. Now, there is still a lot of debate when you heat the sodium hypochlorite outside the oral cavity, and by the time you take it to the tooth, it reaches the body temperature. But also, as compared to that, the Endo Irrigator Plus, which my device was or is undergoing a redevelopment, has warmer at the tip. So constantly 60 degrees hypochlorite keeps on flowing into the tooth without reaching to the body temperature. But there is another method which is called as intracanal heating, which was introduced by Woodmansey and also Alfredo, who is promoting this technique. So here you can use a down pack device, touch and heat, or any down pack tip you have, and activate it when it is filled with sodium hypochlorite for about 3 to 4 seconds. And with 3 to 4 cycles, you can actually activate the sodium hypochlorite in by increasing the temperature, which will have more effect, or it will increase the efficacy of sodium hypochlorite. Now, here we really need to understand whether we are really going to use a down pack tip which heats up to about 150 degrees Celsius temperature minimum. But we really need to know what is the boiling temperature or boiling point of hypochlorite. So there is another one thing which I just told Saurabh and Anand, that couple of things coming. This will be one of the thing which will be again made in India at a very reasonable cost, where you can use this because you don't want to really damage your downpack tips for using it for the intracanal heating. So finally, what are the points to be remembered is the taper decides the volume of irrigant in the root canal system. As I said, I am a proponent of 6 taper. Wherever possible, go to 6. Syringe and needle irrigation, always use 30 gauge needle. Now we do have the tapered needles, so use that. Activation by sonics or ultrasonics is advisable. My choice will be air sonics because it is safe and it is effective. Replenishment of the solution is critically important, and negative pressure irrigation removes the vapor lock, and it is extremely safe. So these are some of the points which you need to remember. Just to conclude, I am going to show you a couple of cases here where huge lesions like this have healed with an irrigation protocol, which I just Okay.
Yes, sir. We are live, sir.
Okay. All right.
Few technical
Okay, so
issues,
then
but
you can see huge
we can
lesions
continue.
getting healed. Whenever you see the furcation lesions, expect that there will be lateral canals and multiple portals of exit. You will see your lateral canals, the trifurcations, the recurrent canals, the apical ramifications, the interconnections, and the splits and the trifurcations. So the point here is we have to treat the root canal system in 3 dimensions. And when the lateral lesion is present, there is a periradicular lesion. That means we have to do intentional cleaning. And when you are dealing with the wide canals, always go for negative pressure irrigation, because the cannula needs to be placed into the apical 1/3, and that is the most effective way of doing irrigation, because it treats the whole length of the canal, and then you can fill all those ramifications and anatomical variations. The isthmus shaping and cleaning, I stressed upon how important it is, or a fundamental step towards long-term success. The interconnections, you need to clean them by impacting by way of your irrigants and activation devices, and also working with, if narrow canals has their own problems of negotiating, the wide canals have their own challenges of removing the pulp tissue and debris completely out. So coming to end, how long do we irrigate? Now, I think this video is self-explanatory how long we are supposed to irrigate. So there is no such volume mentioned anywhere that this much of solution is to be used. More the better. So you have to follow irrigation as your religion. And a very beautiful picture here. This is actually a beach which resembles the shape of the root. And you can see a lesion, periapical lesion like this. So we have to take care of this periradicular disease and stop its progress, and provide a solution to the patients by allowing them to retain their natural foundations. So to end the presentation, just have a look at this video, which actually will tell us that what are we supposed to do. And we really don't know what works many times. If manual dynamic agitation does not work, switch to ultrasonics. If the ultrasonic doesn't work, you may have to switch to sonics. If it still doesn't work, then we'll shift to negative pressure, and finally to intracanal heating. But finally, we have to make a goal, and that is our goal, to completely disinfect the root canal system. So there is no success formula. As a clinician, we have to keep on trying few things and stick to a protocol which gives you consistent results. So with this, I wish all the master class participants a very progressive endodontic journey. Although this is my cycling route, I was discussing with Saurav and Anand that I do cycling every day, and during this lockdown period, that was the only activity which kept me focused uh, all the time. So fitness is one part if you want to work consistently for a longer time, and that's my email ID. And you can get in touch with me for any queries or questions. I will be more than happy to answer your queries. And I hope it was not too long. Being Saturday night, everybody must be eager to kick off their weekend. And I wish you a pleasant weekend and have a relaxing Sunday tomorrow. Thank you. Thank you, Saurabh.
Yes, sir. Yes, sir. Thank you very much, sir, for a wonderful presentation. We had some technical glitches, but the lecture was very interesting and it kept us glued. And I'll request Anand, sir, if he'll take up few questions from the participants.
Yes, Saurabh. Thanks a lot, sir. Thanks a lot, sir. Mandar, sir, amazing session. I guess your irrigation protocols will make everyone forget their Saturday irrigation protocols, as we fondly talk
I'm
about.
going to go on an education.
Yeah. So now everyone is into the canals and not in the glasses.
Yeah, because I was completely worried that Even today, we faced problems twice. Then I was thinking of going and sitting on the tower now, so that I don't lose my network.
Thankfully, that situation didn't arise till now.
Okay, but the most of the part went on smooth, I guess.
Beautifully, beautiful. It just
Yes,
glitched
sir.
during
Yes,
the
sir.
end
Yes.
during the cases. That was okay. Sir, a few questions I have from a few of the participants. Dr.
Yes,
Nami Rajput is asking, what is the efficacy of twin clean in calcified canals?
calcified canals. That is the indication when when you want to use chelation. Now, when you're dealing with restricted canals, you really cannot call them calcified, but they are restricted canals where you really need to chelate the dentine. Now, if you are using EDTA too aggressively, you may chelate the dentine to an extent which can cause errors. So, if you use twin clean, which is a mild chelating agent, which is again combined with hypochlorite, you can leave it in contact with the dentine, which will soften the dentine optimally, being a mild chelating agent, and will allow the negotiation of the restricted canals in a better way. Now, in my practice, I'm using EDTA gel for mostly I think 4 to 5 years. So I pour twin clean directly into the access prepared cavity. Wait for a minute, allow the chelation action to happen. Also, side by side, hypochlorite clears out the tissue. That gives me a clean chamber to look at. And then it's easy for me to get a catch, confirm it with a DG16 probe, and start negotiating with the hand files. So it is actually helpful in the restrictive canals.
Great. Thanks a lot, sir. So I have one question from our dear friend, Dr. Dharmesh Singh. So he is asking, with twin dent, since it is side vented, tip not
Yes.
allowing the irrigant to reach the apical terminus, thus providing safety. How do we ensure the cleaning of apical terminus? He is basically talking about the apical delta with its use.
Apical delta, let it be whether you use parallel sided or you use tapered. None of the needles is going to enter into apical delta unless you go and sit there. So ultimately, it is activation device which is going to drive the irrigant into the apical ramifications. Our job is to make a solution available in 0 to 1 millimeter of the apical one third and drive that irrigant to your activation devices. So irrigant per se on its own cannot penetrate unless you make it activate it to penetrate further. So tapered concept is to convert laminar flow into a turbulent flow where you are in a better position to auger the debris out in the apical one third to the coronal extent, which may not be a practical solution when you are using a parallel sided needle where you need a lot of force to empty a 5 ml syringe. I hope you all must have experienced how much pressure it takes to empty a syringe with 30 gauge parallel sided needle. So
Yes, sir.
it's the ease of delivering the irrigant. Plus, you are not doing a forceful irrigation because there are two vents, and there will be a turbulence in apical one third because there are two ports, and you will be in a better position to auger the debris out. That's the whole point. Apical ramifications is completely cleaned with the activation and not by passive irrigation. That is what I believe.
Sir, I hope you have some time because I think so Dharmesh sir is in good mood and he's asking
Yes,
quite a
yes,
few
I have
questions.
time. Provided my
So
network.
one more question from Dharmesh Singh. In a
Yes.
slightly curved canal, prepared to 2504 tip and taper, can we expect a 30 gauge side vented irrigation needle to reach the apical terminus? And even if so, can we expect it to remove if already existing or prevent the formation of an apical vapor lock, keeping in mind that the ment is 2 mm away from its tip?
Quite a long
So the canal
question.
is, yeah, so I'll just repeat the important points. So the canal is prepared to a 2504 and he's talking about a 30 gauge side vented irrigation needle and how will it take care of the AVL, the apical vapor lock?
See, apical vapor lock cannot be taken care by irrigation needle to start with, because unless you break the apical vapor lock by something which customly fits into the canal, or you pull the irrigant with negative pressure. That these are the only two methods with which you can effectively remove the apical vapor lock. Now, placing the irrigant needle as close as possible to the apical terminus to get rid of the apical vapor lock, you are inviting hypochlorite accidents, because there is no control over your irrigation. Plus 2504, that means after 1 millimeter, it is about 29. So you are good 1 to 2 millimeters away from the apical terminus.
Yes.
So in order to make the solution push 2 millimeters ahead of the needle tip, which is a challenging job in considering the stagnation plane, you are bound to apply some pressure. I hope Dr. Dharmesh agrees with this. And when you do that, then you are inviting accidents. So I don't think in any of the situation with needle placed 2 millimeters away from the apical terminus, you can get rid of the apical vapor lock.
Okay, thanks a lot, sir. Sir, what is the taper of the twin dent?
Twin dent is 3 taper.
Okay, and the apical size?
Apical size is almost 29.5.
Oh, wow, that's beautiful. So, one question from Dr. Muniba Ansari: irrigation protocol in teeth with a wide apical foramen or open apex, basically, and especially in teeth close to the maxillary sinus.
Now, if you confirmly know that the roots are into the sinus, that is the only way CBCT will tell you whether the roots are involving in the maxillary sinus or not. Even if they are not, there are some chances that the solution can extrude into the maxillary sinus. So one thing is the negative pressure is the best way in such situations. If you're dealing with wide apical foramen, then negative pressure is the only solution. Or if you are doing a positive pressure irrigation, you have to be very careful about not applying any pressure. And never
changes in the concentrations.
Sorry?
Any changes in the concentrations of the solutions? Some people do recommend using a diluted hypochlorite.
If you are dealing with a central incisor, for example, which is an open apex where you need to do apexification, then, or in a pediatric or young patients or young permanent tooth, you can very well reduce the concentration to about 1 to 1.5 by diluting hypochlorite.
Thanks a lot, sir. So, most common question: sodium hypochlorite accident management.
Accident management. Okay,
From
first.
Dr. Swapnil Magadum. Yeah.
Okay. There can be 3 situations. One is you spill the hypochlorite into the patient's mouth. And now I don't think anybody will do that because everyone is using rubber dam. I hope so. So that can be avoided by using rubber dam. If it happens, if you're not using rubber dam, ask the patient to rinse. Patient may develop some ulcers, which you will have to prescribe some anti-inflammatories or some astringents. Second type of accident can happen is irrigating, the patient suddenly starts experiencing excruciating pain or sudden bleeding from the canal. That is when you have extruded hypochlorite into the periradicular tissues, for sure. Now this happens when you lock the needle while doing irrigation. That is commonest error by clinician. And also trying to irrigate into a canal which is not optimally shaped, where you place the needle and there is no space for solution to flow back. So it is acting as a plunger, and then it deposits it crosses the periradicular tissues. Now, if that happens, rinse the root canal with normal saline, with lot of normal saline to neutralize the effect. If the canal is bleeding, place some cotton pellet and wait for a couple of minutes to arrest the bleeding. Normally, when you irrigate with normal saline, the concentration of hypochlorite is neutralized. Patient may continue to have pain for a couple of days, where you can prescribe anti-inflammatories or ask the ice applications. And third type of accident is injecting hypochlorite as local anesthetic. Now, if you will be safe if you have done it for infiltration. You can actually give some cuts over the mucosa and allow the bleeding so that most of the solution is out. If it is block given for sodium hypochlorite, then it's a situation where nobody wants to be. So always use a colored or color coded syringes for hypochlorite, or use cartridge syringes for local anesthetic, so you don't do this blunder. And in severe cases where you see ecchymosis or where you have exceeded the venous pressure, you may have to resort to prescribing antibiotics and maybe sometimes steroids.
Okay.
If there is an involvement of maxillary sinus, then do consult an ENT surgeon for further opinions.
Great.
That's how you
manage. I wanted to ask you about the role of steroids. Do you recommend using it routinely in a hypochlorite accident, or only if it is very severe?
Only if it is very severe. Normally, solution in periapical tissues, 1 or 2 days discomfort is very well taken care by anti-inflammatories and ice compressions.
And your opinion on injecting local anesthesia immediately in that area?
That is only a symptomatic relief.
Okay.
That will act as a symptomatic relief if there is excruciating pain. Okay. But yes, you can do that.
Okay. So, irrigation protocol for cases with abscess, irrigation protocol in calcified cases or cases with pulse stones.
You want me to mention the difference between protocol? No, everything is separately. If you're dealing with abscess, for example, you open the tooth. Actually, I had a very beautiful case where I opened the tooth and it was a pulsating discharge, initially with pus, then the inflammatory exudate, and then frank bleeding. So it took me about 15 minutes to completely stop that process. Still under microscope, inside the canal, I could see the fluid movement. So in such cases, when you open the tooth and you see pus oozing out, do not use hypochlorite immediately. Flush it out with normal saline. Let all the pus completely drained out. After the pus is drained out, next will be the inflammatory exudate. That also you clear it out with normal saline. And only after that, you start using sodium hypochlorite. Otherwise, in vital cases, in non-vital cases, in swelling, in whatever way, the protocol of irrigation remains same as it was shown in the traditional or conventional irrigation protocol. There is no change. So it is not that you don't use hypochlorite. It's only initially you don't use hypochlorite when there is frank pus.
Obviously, in fact, the bacterial load is too much. We need to use hypochlorite.
When there is pus, yeah, after it has been completely, yes, if it is oozing out, then let it ooze out and then use hypochlorite.
Yes, fair enough, sir. One last question, sir, from Dr. Manan Vyas. Any issues if we use EDTA gel also on the rotary files with hypochlorite in the canal rather than without EDTA gel?
See, I don't recommend, or myself, I don't use EDTA gel with rotary instrumentation. Yes, you may use it with hand instruments because you want to achieve a glide path, because you are gaining an initial entry into the root canal system, for which to have a reproducible glide path, you need some chelating action, which EDTA gel will provide. It also has an emulsifying effect, which will allow the debris to be kept in floating state. But once the initial glide path has been done with, when you switch to your rotary files, only when you have glide path, correct? So once you have glide path, then what is the point of using EDTA gel and chelating it again? And gels, they tend to accumulate a lot of hard tissue debris, and form a plug. And in our situations, we resort to irrigation only in the end. By that time, it has become a concrete. So, so I don't recommend EDTA gel with rotary instrumentation. It is better to be with
We are
liquid.
manufacturing it.
So it is better to be liquids because it is easy to refresh. Gels are not easy to refresh. That's the whole point behind that.
Dr. Saurabh, can you be, yeah. Dr. Saurabh, if you have any questions, please.
No, Dr. Anand, I think majority of the questions have been summed up, and sir's webinar was also quite thorough, that many of the questions got answered on its own.
Yeah, pretty much.
Yes. Thank you, Mandar sir, for a wonderful lecture. And I feel many of us would be now inquiring and looking into pets and the endo activator and the activation system of yours, sir.
Yes, it is. It is. Now, as Dr. Anand said, that there is going to be a made in India campaign. So
yes.
See how
we
it
look
goes.
forward to it, sir. We look forward.
So you will
And
be the
the
star
idea is
campaigner
only
in
to
that
make
campaign.
it quite affordable to our clinicians. That is the whole point.
So exactly 15 days later,
Exactly,
we'll be launching our Make in India campaign, which will be promoting the Indian manufacturers, Indian entrepreneurs, Indian products, everything Indian. We'll be dedicating a day on World Dental Association. That would be the Monday of every week, which we dedicated for it. And this campaign was thought about, and you were a very big part of that entire thought process. So this campaign was
Yes,
thought
but
about
then
at least 3-4 months ago.
I will not. I would not want to sound it promotional, but people need to think about and see what is actually efficient, and then take a call. It is not that they should buy my system, but they have to. They should be looking at the concepts. Once they understand the concept, it's up to them what to use. So my idea was to give them concept. So it's not about the products.
Totally agree with you, sir.
Right,
And
right,
all the
sir.
concepts that you talk about are always backed with proper concrete science. So you have actually plastered that concrete into our heads now. So thanks a lot, sir, for the amazing
Yes.
session. It was beautiful listening to you again, and hope
Thank
so we'll
you.
catch up again very soon.
Yes.
Yes, sir.
Thank you
Bye-bye,
so much.
everyone.
Thank you,
Good
sir.
night.
Good evening.
Eid Mubarak once
you.
again.
Take care.
And see you all day after tomorrow with Dr. Zahir Al-Taki. Bye-bye.
Goodbye. Have a wonderful weekend. Bye.
Bye. Thank you, sir. Bye.